All right. Thank you so much, everyone, for joining us this evening. On behalf of the Epilepsy Foundation of Michigan, I want to thank you for joining us for this discussion about the critical role of rescue medication in epilepsy treatment. My name is Nicole Fitzpatrick. I'm the Community Program Specialist with the Foundation, and I'll be the facilitator for our discussion today. With that, I'd like to welcome and introduce our esteemed presenter for tonight's discussion, Dr. Ryan Keating. Dr. Keating is an epileptologist and an assistant professor working with the Department of Neurology and Ophthalmology at Michigan State University. And he also serves on the Professional Advisory Committee with the Epilepsy Foundation of Michigan. Thank you so much and welcome, Dr. Keating.
Thank you very much for that introduction. Um, like, so I've been in and taking care of epilepsy patients independently for the last about 5 years, and before that, I did my fellowship over at Henry Ford. And since then, I've amassed a number of patients with epilepsy, and in the adult world. Rescue therapies were kind of a thing that were thought of as a pediatric predominant thing. And now, as of 2019, there's been a lot of advent and I guess, a renaissance with being able to use these rescue therapies with return to new products due to the stigma of the previous products in adulthood. And so that's kind of a little bit of an introduction to things, but we'll kind of go through the lecture. I'll go to my next slide now. And so on my next slide is just disclosures. I currently have no financial disclosures at this time, so I'm not speaking on behalf of any of the medications that we're talking about today. I have no skin in the game other than it helps my patients. So we'll go to the next slide. And so the first and most important thing that I think with regards to rescue therapies for children and adults is a seizure action plan. Every patient with epilepsy should have a seizure action plan. And so if you don't, I definitely recommend talking to your healthcare provider about developing a seizure action plan. A seizure action plan is an individualized plan for a person with epilepsy to determine what to do in the time when somebody is having an acute seizure, and whether that be at work or at home or at school, what is that plan? And like I said before, that plan is individualized with your healthcare provider and then shared with your family, your coworkers, your work, and sometimes your school, so that everybody is on the same page, or at least has a page to be able to review at that time when you need help. And so the Epilepsy Foundation actually has a wonderful number of resources for this seizure action plan. And so if we go to the next slide, we can see an example of that seizure action plan. And so this fortunately not only comes in English, it also comes in Spanish, Chinese, Korean, Vietnamese, Tagalog, and Ukrainian. And I'm sure that there will be more languages as needed. But this is a great way to talk about each individual person, what kinds of seizures they have, what happens during their seizures. And then there's a nice checklist as to what to do next in these. And so a lot of it is standardized, but it is helpful in moments or times where everybody who's not used to witnessing seizures needs to know what happens and how to take care of each individual patient with epilepsy. And so then at the bottom of that page, and what I didn't include on the second page is if there's a rescue therapy needed. And so we'll talk about that. But if you go to this website, you can definitely print out a PDF. This is another example of that action plan. I kind of like this one a little bit more because it gives you imaging as to what you're looking for or what you're looking out for in specific plans, and when somebody needs the next steps of care, whether that be a rescue therapy such as a rectal therapy or an oral therapy or a nasal therapy, or if that's somebody, it's time to call emergency services. And so it's a very easy stoplight method to go through of what to do for patients when they're having seizures. And so we can go over to the next slide. And so rescue therapies, or the definition is any treatment that's additive or additional to your typical anti-seizure medication regimen to decrease the frequency or duration of the acute seizure. And so for some people who have implantable devices like a vagal nerve stimulator, that's a simple magnet swipe that may allow the patient or caregiver the ability to give an additional stimuli. Sometimes we don't have a magnet swipe, or we don't need a magnet swipe when our heart rate increases. And our heart rate monitor goes off on some of these VNS therapies and allow us to do an additional treatment based on heart rate. We can do things like an extra dose of anti-seizure medication. And so you can have a plan with your provider that says, if I have this number of seizures, or if it's this time of the month when my seizures are increased in frequency, or I have something like catamenial epilepsy, which means I have epilepsy in correlation with my menstrual cycle, then I can take an extra dose of medication to further protect me at that time. It's kind of like, if I kind of talk to my patients a lot about epilepsy and the medications for treatment of epilepsy being like the seatbelt or an airbag in a car. And so we know that if we're getting in a car to go to something that's more risky, like a race or something like that, we might use a 5-point restraint because we have a higher propensity to get in an accident. And so very similarly, if we know that we have typical weeks where we're more likely to have seizure, then we might want to give an extra dose of an anti-seizure medication. That is very similar to oral dosing of a rescue therapy. Oral dosing of rescue therapy has been in the past and has been concurrently used as oral dosing of a rescue therapy. There are some oral dissolving tablets and or film strips that can be used as certain medications. Those are of kind of discretion up to your healthcare provider if those are options. But those are a little bit different than the typical anti-seizure medication that we take. Sometimes those are benzodiazepines or benzodiazepine containing compounds. That kind of predecessed rectal dosing of therapy, and so we'll talk about that shortly. Once again, that's another benzodiazepine taken acutely in the time of either a cluster of seizures or a seizure that lasts for too long. And that came out in about 1997. And the newest iteration is that of nasal dosing of a rescue therapy, which is a nasal spray of a benzodiazepine, which we'll talk about shortly. And so we'll go into talking about the next slide, which is kind of going through rectal diazepam, which is also called Diastat or Diastat Acudil. Very helpful. So this was the first medication that was to market that was as a rescue therapy that had a different mechanism of action than the oral therapies that predecessed it. It was introduced in 1997, and the administration instructions are actually included on the package. And then also, if you're interested about how to administer or how to tell people in a seizure action plan how to administer, the Epilepsy Foundation actually does have instructions and a video on how to do so. And so following those instructions or guidance to follow those instructions are important. The companies who do provide this and the other medications, the nasal medications, do have support to be able to make sure that caregivers and anybody who's involved in the seizure action plan understands how to use these devices. They also have teachable devices so they can be attempted by family members or caregivers before it is the critical time to give it. This medication is FDA approved for patients who are 2 years and older. Like I said, as before, it is FDA approved for treatment of seizures lasting longer than a specific duration or with typically 5 minutes or longer of seizure activity, and or people who are having clusters of seizures to stop or prevent that cluster from continuing. The duration to action when we give it is about 15 minutes. The peak effect is about 1.5 hours, and the duration to elimination is about 48 hours. And so we notice with these medications like diazepam and midazolam, they're very quick in the system, and then they seem to stick around for a while. And so there's this benefit as it stays around in the system. And that's why we approve it for cluster seizures, which we'll talk about in a moment. The other big thing that people ask me about these medications is, when do I give another dose of it? Usually it will be instructed if you need to give another dose on the patient instructions. And that's typical with your healthcare provider if they feel an additional dose is necessary. And then the other question people ask me all the time is, how long do I have to watch somebody, or when do I have to call 911? Sometimes that's part of the seizure action plan individually. And so going through with your healthcare provider, what your seizure action plan is specifically and when to call 911 is important. The other good kind of markers is if after you give this medication, the seizure activity continues for another 5 minutes, then the concern is that the patient may be going into what is called status epilepticus, which is unrelenting seizures that are unlikely to stop by themselves. Or if the patient is having trouble breathing or turning blue or showing other signs of distress, it's time to call 911. And then another question that people ask too with these medications, or specifically with the diazepam, the rectal diazepam, is how long should we watch people after giving this? And the recommendation is about 4 hours after administration for side effects or return seizure. If a patient is sleepy after giving this medication, that can be typical. You can let them rest. You don't have to try to keep them awake or anything like that. I would just watch for additional signs of seizure. So we can go to the next slide. And so the next slide, I titled this, It's About Time, because it's almost been about 22 decades before the next rescue medication came out. And that's a very, very long time to allow, when this medication initially came out, for pediatric patients to become adults and then not have something that is as easy to administer as a nasal spray to use as for a rescue therapy. And so I will tell you, there's a lot of stigma and issues around being able to use these rectal diazepam and also the Diastat in adults, and people may be uncomfortable to use them. And so as part of a seizure action plan, sometimes that's become very difficult with regards to not only the patient feeling that, but also the caregivers or anybody who's trying to help. And so these are very simple looking. These look, they're smaller, but they look no different than like a nasal spray that you would use for allergy. They're just single use. And so you would put them up somebody's nostril, which in an acute seizure, an acute repetitive seizure, when somebody's not responding, that is something that's much simpler to do than trying to get a device in or around somebody's rectum. And so this has kind of changed the game in the ease to use, and people don't have to inhale when they're giving this. And so the patient does not have to be conscious when giving this. They can be in the throes of a seizure or recovering from seizure. And we know that if the nasal spray is going to work, it's going to actuate up into the nasal passages and it's going to get taken up in the oral mucosa or the nasal passages. And so the two medications that have come out are nasal midazolam, which is called Nasolam, and nasal diazepam, which is called Valtoco. They're different formulations or different benzodiazepines, and their age of administration is a little bit different, but they have very similar duration to action and peak effect and duration of elimination. And so if we look about that, the duration to action is 4 to 10 minutes, so a little bit more rapid than even the rectal therapy. The peak effect is about 12 to 48 hours. And so we notice that we have this long peak effect, and then we don't start eliminating the medication until 48 hours thereafter. And so these medications were approved for cluster or acute repetitive seizures. What that means is a sudden increase in seizure frequency with multiple seizures within a 6 to 24-hour window. A lot of the education on these is usually 2 or more seizures in that window. And then that's kind of what has been FDA approved. A lot of epilepsy specialists and clinical neurophysiologists and neurologists have gone about using this as a off-label indication for seizures that are lasting too long. So a seizure lasting longer than 5 minutes is very far. It's about 20 standard deviations outside of the normal of how long a seizure should last. And the likelihood that it's going to stop on its own is very, very rare or low. And so in the time where moments matter to stop seizures from happening, a lot of epilepsy specialists will recommend using this medication to stop it. And at that time, call 911. The important thing about knowing 911 in Michigan is depending on where you are, an ambulance can take some time to get to. In a study that's been done across the United States, typically in urban areas, it can take anywhere between like in low urban populated areas, about 5 minutes. In high urban populated areas where it's hard to travel from point A to point B, upwards of 10 to 15 minutes. Outside of that, in rural areas, it can sometimes take 20 minutes before somebody is able to make it to a house of somebody seizing. And so using something like this while we're waiting for emergency services that can give these medications by IV or by subcutaneous injection is important, because a large percentage of patients may stop seizing and not have detrimental side effects from something like status epilepticus. Now, I'll say with regards to the use of these, I recommend in a seizure action plan and with your healthcare provider that you discuss what is the right time and place to use these medications, and they will help you with that. And that piece of paper is a good way of kind of breaking the ice in this conversation. And so when we talk about risks of these medications, the big thing with risks of these medications, there's really not very much risk in association with these medications. When the trials were done, less than 5% of people had some kind of side effect from these medications. And the risks were, some people had nasal irritation, some people had minor sedation. And so when I go into the medications individually, the vast majority of people, when they took this, were able to return to their normal activity within about 2 to 3 hours after taking the medication. And so that's all very important points, and very important with regards to the concerns that people have when they give benzodiazepines to people. With regards on how to administer, very similar to the rectal diazepam. The individual medications have administration instructions within them, and also QR codes to videos with administration instructions, and the ability to get tester devices and things like that. And also the Michigan Epilepsy Foundation has videos and information on how to administer these. And so we'll go on to the next slide where I specifically talk about certain medications. The first one I'll talk about is nasal midazolam. Like I said before, this was introduced in 2019, so it's the second to market medication. It's approved for patients who are 12 and older. So typically the older population of adolescents, and then that's because there's really only one dose that exists. And so that's a 5 milligram for 1.1 milliliter of the spray. The initial dose is in one nostril, and the second dose is in the opposite nostril if after 10 minutes the patient hasn't responded. And so the reason that we switched nostrils is this very long study that was done in proof of concept, where we found out that our nasal passages actually do have some evidence of fluctuation in the course of about 10 to 30 minutes. And so we can insert into one nasal passageway, and that might be blocked off or swollen. But then in that time, the other nasal passageway will be open. And so giving that medication in either passageway, if we haven't had improvement, we'll likely get the medication where it needs to go. The clinical trial that was done on this medication showed that 80% of people were responded to this medication after 10 minutes, and the response was termination of seizure. And then they had an absence of recurrence of about 60% of people after 6 hours on the medication, up to about 24 to 48 hours. And so you can see that these medications not only terminate seizure quite rapidly, but they can also prevent recurrence for a short period of time thereafter, which is why it's so beneficial in cluster. Now we'll go on to the next medication, which is the nasal diazepam. So we'll go to the next slide. So this medication was introduced in 2020, and it's FDA approved for ages 6 and older. And because of that, there's a very large difference between a 6-year-old taking it, a 10-year-old taking it, a 15-year-old taking it, and a 20-year-old taking it. And that's predominantly based on weight. And so if you're 6 to 11 years old, the dosing is a little bit more robust in those kids. And depending on your weight, you can there's 3 different types of sprays. So there's a 5 milligram spray, a 7.5 milligram spray, and a 10 milligram spray. And so you'd either do one spray of one medication or two sprays of the same doses. And typically, when people do those two sprays, you would want to use the other nair to do the other spray. And that is a full dose. And so once you take that in, there's really no repeat dose thereafter. And then if you're 12 years or older, depending on your weight, but for most adults, it's two sprays of the 10 milligram spray to equivalent or equal what would be a full dose for that medication. The data is pretty similar to Diastat, and so it was actually proven based on the Diastat model of like its efficacy and its duration of action and things like this. And this was just a new formulation of diazepam or the rectal formulation to an or nasal spray formulation. And so a lot of the data is very similar, and the side effect profile is very similar to that too. So we can go to the next slide. And so I kind of touched on this before, but how do you start a conversation about these medications? And so things change very rapidly. And although it seems like 5 years is a very long time in medicine, it's not always that long for information to get down to the masses, especially in rural areas. And so one of the best ways to kind of introduce a conversation about this is asking your healthcare provider, what is your seizure action plan? And can we go through a seizure action plan to fill it out so we can discuss it? And in that will come up, what is our rescue therapy plan? I believe that, or I feel personally that all patients should have a seizure action plan, and most patients should have access to some kind of rescue therapy or rescue plan for their seizures. And so a lot of questions that will come off of this conversation will be, well, what is your seizure frequency or how often are you having seizures? And so coming with that information as well as an educated patient will be helpful to determine, like, do we need to increase your dosing of your medication that you take every day, or do we need to use this anti-seizure medication, or sorry, this rescue medication to tamp down or use as something we have in our back pocket in case something happens. And so then the next slide is my last slide. And so that's kind of all the information I had. I tried to keep it brief because I really want to answer some questions that you guys may have, since I am with you guys for a little bit. And so I'm happy to answer any questions that come up.
Okay, so we have a couple of questions in the Q&A, and so I'll just read through those. The first one we have you seen cases where the rescue med no longer works as a first line of defense in stopping the seizure?
Yes, I have. Um, Typically, in a sense of treating somebody who is having what is impending status epilepticus, we do try these medications. And so, from trials way long ago when we used to figure out what would work in EMS to stop seizures, it does not stop all the seizures. And so that's why when a seizure lasts for too long, when a seizure lasts for over than 5 minutes, and we're giving this medication to try to stop that seizure from occurring, if the seizure isn't stopping or if there is evidence of distress, I always recommend calling 911 because they can offer other support, including respiratory support, cardiac support, and sometimes IV medications to assist in that critical time period before they get to the hospital, and we can evaluate the patient and administer IV medications. In regards to treatment of acute cluster seizures, which is the FDA recommended approved use of this medication, if it's not reducing the frequency in the short period of cluster seizures, then consideration for medications that would be more long-term, like anti-seizure medication regimens, like your everyday dosing medication, may need to be increased to help with reducing the quantity of those cluster events.
Great, thank you so much.
Mhm.
And the next question we have is, I get cold sores in my nose and the front of it. Can it cause cold sores?
I would talk to your healthcare provider about that individually. Unfortunately, that would be something that would be individual and outside of the package insert or any information that is provided. And so I can't really answer that question specifically to you.
Okay, thank you. In regards to nasal sprays, how long do you think one nasal spray lasts before being empty? How many times seizures and how long do they last before expiring?
So this is a great question that I get asked a lot. So the nasal sprays that are given are one-time use only, meaning that once you use that spray, it is no longer able to use. Actually, what happens with the bulb at the back of it is it stays within the device, and so you can't pull it out again and reuse it. The medication is already given, and so they're one-time use per each nasal spray. The other question regarding expiry of these medications. Regarding expiry of these medications, the expiration date is specifically based on the plastic container that it is held in. And so those have been approved by the FDA to be able to stay shelf stable for upwards of a year. The medication within it, whether it be the midazolam or the diazepam, can stay shelf stable for much longer. And so it would be up to the individual discussing with their healthcare provider, can they keep those and use them in situations where they may need them as an additional rescue or things like that. But I would say the following the expiration date of 1 year time is important. The only other caveat being these are rescue meds, right? So we're putting them in places where we need them for rescue. That being said, if we're putting them into our glove box and we're in a Michigan summer and temperatures can get in a car up to 150, that can denature or destabilize the product. And so I would try to keep it on your person as much as you can, whether that be in a pocket or in a purse or in your house, and try to avoid keeping it in a car, especially in the summertime, because that can make it unstable.
Great, great information. Thank you.
Mhm.
How often is it safe to use a rescue nasal ASM?
Yeah, so there's been no maximal dose that has been said like, oh, by far we don't recommend using it more than this. I will tell you that if you're using it more days than not in a month, that's probably too much. You might need something with regards to your day-to-day therapy to be increased to be able to help with this. Now, that being said, in listening to people who are much smarter than me with regards to care of epilepsy and who've been doing it for a lot longer than I have, names at Ivory Towers, and like Dr. Hirsch and things like that, most people have said using this 2 to 3 times per week isn't enough to drive addicted potential. So you're not causing yourself to become addicted to this medication if you're using it 2 to 3 times per week in the short term. Now, if you're using it upwards of 12 times a month, that's a lot, and you should talk to your healthcare provider about increasing your seizure medication or considering epilepsy surgery or something like that. But really, the sweet spot of this medication is something that we're using once a month or less to rescue us in times where we may need it.
Right, thank you. And what is the name of the rescue ASM in a film strip?
Um, so there is no rescue anti-seizure medication or so there's no rescue therapy in a film strip. There's a rescue medication called clobazam, that is sorry, it's an anti-seizure medication called clobazam that comes in a film strip. And so because you don't need to swallow that, some people have used it off-label as a rescue therapy. Also, there are oral dissolving tablets for a lot of the benzodiazepines that exist. And so some people have used that off-label for the purpose of rescue. I typically do not use those now with the advent of the rescue in nasal therapies. 99% of what I prescribe at this juncture is nasal therapies for rescues and the one-time use ones specifically that are non-compounded through the companies.
Okay, great, thank you. Um, that's all the questions we have in Q&A, and I do have a couple of questions. So continue to put your questions into Q&A if you have any. Um, does a person need any special certifications in order to administer a rescue medication?
Yeah, so that's a great question, and they do not. There's no specific certification, there's no experience of background. These medications have been created and developed, and the device that they use have been developed to be easy to use for any individual. And so the best thing you can do is if you know a person with epilepsy and or you are part of a seizure action plan, seeing the device used in an instructional video is enough to be able to get enough experience. And if you feel like you need more experience, then it is very easy to reach out to have the person who's being prescribed this medication reach out to the company or speak to their healthcare provider about getting testers. I have one sitting above me right now. That's what these look like. They are, sorry, I'll put that right there.
There we go.
Um, they are pretty easy devices to use, and we have demo devices everywhere. And so usually in the rooms with the doctor, we have a demo device, and I have probably hundreds of them, and so I'd be happy to give them to my patients if they request it.
Great. Thank you. What factors are typically considered when determining the appropriate dosage of a rescue medication for an individual?
Yep. So the biggest thing is, well, currently with the nasal medications is weight. It's weight-based dosing, and the other one is age of the patient. And so determination of benefit from age of the patient and weight-based dosing are the most important things and kind of the biggest drivers of are you going to use the rectal diazepam? If you're 2 to 6 years old, that's what we can offer. If you're 6 years old to 12 years old, then the nasal diazepam would be the best thing. And then if you're 12 years or older, you can either use the nasal diazepam or the nasal midazolam. And then there's weight-based dosing in between all of that.
Great. So is there any movement in the direction to be able to use the nasal with the younger as well, between 2 to 6? Or do you think that that will always be?
I don't know. I don't know actually off the top of my head if
Okay.
that's a I'm assuming that it may be. The biggest part of it is that the company that would have to get it approved would have to get additional devices approved for additional weight-based dosing. And so I don't know if that is
In the
one of
in-
the plans or not. Yeah.
yeah, I just know I hear from a lot of parents that and individuals that that would be a good thing.
Yep.
And then
And
we
so
do.
these, so I will tell you, so I will just tell you in passing, these companies that own these medications are very, very, very interested in patient discussions and patient information. And so if you ever want to call up to one of these companies and say, boy, I wish you would investigate something like this, they are very happy to listen. I mean, the company that does Nasalam, they have their own division that's specifically geared towards patient care. And so epilepsy is one of those things where patient support and patient information is very important to these companies. And so if you are feeling that way, or if you wish that certain things would happen, or if you're concerned about the way medications are given, reaching out to them is a very helpful way of trying to enact your opinion, no different than if you were to speak to a state representative or something like that.
That's great information. Thank you so much. We have a new question in the QA. What could happen to someone that uses it and doesn't have epilepsy? I have heard of a couple people that have done this. We did rush them in. We had reported it.
Um, So it's hard to say what would happen to patients who use this who don't have epilepsy because when the studies were trialed, it was trialed in patients with epilepsy. That being said, most medications that are new to concept are trialed on normal adults to trial the medication. And that being said, with the side effect profile being very, very low with these medications, unless the person is taking a concomitant benzodiazepine on a regular basis, the likelihood that they cause detriment to themselves is very, very low if they're taking the appropriate weight-based dosing. And so if a kid or a child or an infant takes an adult dosing of medication, that can definitely be a problem. And so keeping these medications in safe places where kids who don't know how to use them or the importance of using these is a very important thing to do because it's really hard to tell that like this is a dangerous thing to take because it looks, I mean, honestly, like a spaceship. And so being very careful with who has access to it is important. That being said, I do not recommend using these medications outside of the diagnoses that they're FDA approved for.
Absolutely. Thank you so much. Can
Mhm.
you share any examples when rescue medications significantly improved a patient's health outcomes during a seizure? I think you talked about it a little bit during the presentation, but
Yeah, I mean, I've had multiple patients, and multiple patients who I'm currently counseling who are one, scared that when they have one seizure that they're going to have 3 to 4 more seizures in that 24-hour period, and they can do nothing about it except for maybe try an additional dose of medication and hope that that comes into benefit quickly enough to prevent it. The other thing too is that I have patients who very typically, when they have their breakthrough seizures, which are very, very rare, they can last for greater than 10 or 15 minutes. And those patients using the nasal therapy have been able to have EMS come to their house and say, "You're coming back to your normal self. There's no reason to send you to the hospital to be evaluated." The other group of people with cluster seizures, I've been able to give them some kind of control in those moments where they're fearful that they're going to have more seizures, to give them something that they can do actively or proactively. I guess reactively would be the best answer to control seizures going forward. And so I think that it's something that we can give our patients with epilepsy to be able to, at a high likelihood, prevent them from having the next seizure, or give caregivers the ability to do something while they're waiting for EMS to get there, and otherwise can only do seizure protection methods like turning somebody on their side, or moving things out of the way that are dangerous if they strike them, or making sure their airways protected and things like that. And so it gives the patient and the caregiver a little bit more control to be able to try or do something in those moments where it's scary.
yeah, great. Can you discuss any potential interactions between daily epilepsy medications and rescue medications?
So this has been touched on multiple times. There are no interactions with anti-seizure medications and rescue therapies. That's a benefit. That's why they were created and followed. Now, that being said, if somebody is taking large doses of regular benzodiazepines, speaking with their healthcare provider to make sure that it's safe that they take these medications in concert or in conjunction is very, very important. But if you're taking typical dosings of anti-seizure medications, then there should be no interaction between this and your rescue therapy.
Great, thank you. What should patients do if they experience side effects from rescue medications? Are there ways to mitigate these side effects?
The risk of side effect is very, very low in in these therapies. And the risk benefit is one of those that we have to outweigh. And so, like, is the nasal irritation that occurs if we get this medication worth it if somebody is having a reduced frequency of seizure for the next 48 hours? Is somebody who is seemingly unconscious from seizure, who's been seizing for the last 5 minutes, going to worry about nasal irritation or worry about some somnolence in the next 4 hours, when the thought is we're either preventing them from going to the hospital or preventing them from ending up in the hospital in status epilepticus? And so, in the realm of where we are using these medications, the side effect burden or likelihood is very, very low. Or the risk benefit of these is very, very high potential benefit for very low risk. And so, if we do face side effects or notice side effects with these medications, we should speak to our healthcare provider. That being said, with now the advent of nasal therapies for people over the age of 6. If rectal diazepam isn't right for somebody, or if it's difficult to administer, switching to nasal spray was an appropriate thing to do. Vice versa, too, if nasal spray is impossible to give or and unlikely to be able to be given in either the mechanism that is given or some alternative mechanism, then consideration for the rectal therapy might be something that's warranted.
Very good. When you were talking earlier about, with the nasal, somebody had brought up to me once the question of if someone has a cold, um, can that reduce the effectiveness of the nasal spray? Like if they have a sinus and, nose congestion.
Slightly, but not significantly, not significantly.
Okay,
And so
great.
it shouldn't be a limitation to not give the medication.
Awesome. Thank you.
Mhm.
What steps should be taken if a rescue medication does not seem to be working as expected during a seizure?
So if it's during a seizure that's lasting too long of a duration, then consideration should call 911.
Yeah.
And so if you're giving this medication after 5 minutes of seizure activity and the seizure has not stopped or the patient is not returning to their normal self or there is some kind of evidence of distress, then calling 911 is important. One of the two medications do have a second dosing, one of the three medications do have a second dosing in association with it. The rectal diazepam can, but it's up to individualized plans. The nasal diazepam does not. And so if a second dose is warranted, you can give a second dose. But I would still say if you're giving a second dose or you're worried that somebody is not stopping seizing after 5 minutes, then you should call 911. If it's being used for acute cluster of seizures and you give it after the first seizure, and then the person goes on to have the clusters that they had before, so has an additional one, but is coming back to baseline, at that time it may be warranted to call your healthcare professional to come up with a plan of what to do for that acute cluster. And that's sometimes in part or parcel with the seizure action plan that has already been formulated. And so those questions may already be answered in a seizure action plan.
Okay. And is it recommended that every time someone uses one of these rescue medications, they should be following up with their healthcare provider, their neurologist or epileptologist after the fact?
I would say it would depend on the seizure action plan.
Okay.
It's not a cookie cutter ubiquitous
Yeah.
thing.
Yeah.
And so every individual plan is different. Everybody's stage of epilepsy and what the expectation is month by month is different. And so sometimes when we're waiting for patients to get epilepsy surgery and we're maxed out on medication, what we can offer is the rescue medication. And so there may be certain things in that seizure action plan where we say, like, yes, we're going to use this med, and yes, we know we're going to use it this many times a month. However, in these cases, when it is not benefiting you or it is doing this, then that's when you need to reach out to us.
Okay. Great. And how do healthcare providers monitor and follow up with patients who are prescribed rescue medications?
And so it should be part of a regular visit to discuss the medication, if refills are warranted, did we use the medication, how did that plan go? It's indifferent to how we talk about seizure like anti-seizure medications.
Okay. Wonderful. Well, that answers all the questions that I have. Oh, I have a new one now in the chat. I missed the presentation. Did you cover what to expect after giving rescue meds to a child? Is there any drawback to giving it if you aren't sure of the length of a seizure?
So that's a good question. And so, like I said in the presentation before, if a seizure has lasted for longer than 5 minutes, you should be giving this medication, but everybody has a seizure action plan. And sometimes we don't know when a seizure starts. And so sometimes we have to assume. And I've had individual seizure plans where people have seizures out of sleep, and we recognize that their typical seizures last a certain duration. And so by the time we get to them, we don't know if it's been 2 minutes, 5 minutes, or 10 minutes. And so sometimes the seizure action plan will say to give this medication. There is typically and I guess in the presentation that had been missed, there is very low risk in giving these medications and very high potential for reward. And so I would always advocate for giving these medications and then seeing what the response is, or considering calling 911 as we're giving these medications if we're concerned about the duration of the seizure. After the medication is given, watching the person return to baseline is very, very helpful. With these nasal spray medications, most people within about 2 to 3 hours are able to return to their normal activity. And then in children with the rectal diazepam, it's probably about 4 to 6 hours, but during that time, people can be sleepy. The trend should be to return to normal. And so waiting for that person to return to normal, and if they have another seizure within that time before they return to normal, that is concerning for status epilepticus, and we should call 911.
Great. Thank you. If
Mhm.
anyone has any other questions, please feel free to post them in the QA. So, Dr. Keating, I can't thank you enough for your time this evening to talk about this and to share this information. We know it's such an important and a critical part of care for our epilepsy patients in our community. And so I really appreciate you being here to help share this. We can share the slides when we post it on the YouTube. We can put it in our notes. That's okay. Okay. We
Totally
will.
fine.
Yeah, thank you. And we will do that. And with that, we will let you go back into your evening. Thank you again so much. Wish you all a wonderful evening, seizure free, stay seizure free, and know that the foundation's here for you if you have any questions and follow up. Thank you again, Dr. Keating. Have a wonderful evening.
Thank you.